Focus on mental health echoes very well with its mandate for health, happiness, and dignity for all. This evening, we are discussing on the topic of community mental health care. Let me just give a bit of background. Around the world, what we see is mental health services intend to provide quality care and support for people with mental health conditions. However, in many countries, people still cannot access quality services that respond to their needs and respect their rights and dignity. In fact, in many places, people are subject to wide ranging violations and discrimination in mental health care settings, including the use of coercive practices, poor and inhuman living conditions, neglect, and in some cases, abuse. The last 2 decades, we are witnessing a growing awareness on the need to improve mental health services. However, in all countries, whether irrespective of whether it is low, medium, or high income country, the collective response has been constrained by inadequate legal and policy frameworks and lack of resources. That's always a concern. We don't have enough manpower, enough resources, enough professionals in the field. No matter how well mental health services are provided, alone they are insufficient to support the needs of all people, particularly those who are living in poverty or those without houses, education, or a means to generate income. For this reason, it is essential to ensure that mental health services and social sector services engage and collaborate in a very practical, and meaningful manner to provide holistic support to these people who are in need of mental health support. Mental health across the world is still considered a taboo, a stigma, and especially in African and Asian countries. Several initiatives have been taken by different government and private sector players. Still, it seems like the initiative needs to get bigger and better as the number of people in need of mental health support seems to be increasing significantly, and we're seeing it again and again. With the impact of COVID-19, this issue appears to have escalated even much further. This is why our today's webinar focuses on community mental health, focusing on importance of initiatives and awareness relating to the community mental health and in the present economic situation worldwide. Let me introduce all the panelists of today's session. We have Ms. Shaheen Nafisa Siddiq, Head of Mental Health and Psychosocial Support of BRAC Institute of Education Development in Bangladesh. We are supposed to be, okay. Then we have Ms. Munira Rahman, Founder and Chairperson, Innovation for Wellbeing Foundation in Bangladesh. And we have Ashik Salim, Dr. Ashik Salim, Head of SAJIDA Mental Health Program and this is one of his many hats that he wears to support SAJIDA Foundation. Should we start with, let's start with Shaheen Appa. We would like to know about how would you define mental health, community mental health, and then tell us about what and how BRAC is, what is BRAC doing about it and how it is doing it.
Thank you, Appa. Actually, when we come to talk about community mental health, I would say it refers to the socio-emotional well-being of the people in the community. And of course, we know that the population in Bangladesh, in case of children, the percentage of mental health complication is about 23%, where the adults are suffering almost for about 31%. So it's and then again, most of the people suffers from mental health trouble once or sometime in their life. So that means almost the entire population gets to suffer from something terrible in their life in terms of mental health sometime in their life. So that kind of tells us that the community actually needs a lot of mental health support, and maybe we get the access to some of the people where we have the service going on at the moment, but there are a huge population that remains uh, beyond our reach, and or beyond all the research that has been going on. So it is a concern at the moment how to address the community, and BRAC has taken a major step to address the community mental health. Especially, as you know, BRAC has been working with FDM and population since 2017. It has been a major focus for BRAC to serve the Rohingya community, because this particular population and the community has suffered a lot from a lot of inhumanity and then violence and abuses. So there has been cases of PTSD, there has been cases of um, depression, anxiety, and many more disorders where BRAC felt that they have to develop a comprehensive mental health service. And ever since then, BRAC has tried to establish this para-counselor model, which has been working really rigorously to provide mental health support to the community. And this has been really successful because BRAC has this para-counselor model where the para-counselors are members who visits from door to door, and we have the frontliners who identifies the cases, because frontliners are the community members. So they have an access to all the community people because they understand the community well, and they have connection with the community. So it's easy for them to build a rapport. And when the cases are identified, they refer them to the para-counselors. And most of the cases are usually handled by the para-counselors, except for those where the para-counselor have their own struggles, and they cross-refer those cases to the psychologist, because in the second tier we have the psychologists who rigorously train the para-counselors and supervise the para-counselors. And also when there is a case which needs an in-depth intervention, the psychologists are there to see these cases. And the psychologist also needs capacity building and supervision, and that has been given by expert in mental health. And they regularly get to have supervision. It's actually once in a week that the psychologists get to have the supervisions. It's almost the same for the para-counselors. So this is the rigorous process of capacity building, supervision, and service provision that we have for the FDMN population. We also have the para-counselors working in the mainstream, and similarly, we train those para-counselors. They're also taken from the locality and from the local population. Wherever we are implementing the para-counselor model, we are looking into the fact that the para-counselors are taken from the community and they have an access to the community. And I think it's also worthy to mention that most of our para-counselors are female. So that has actually helped the female population of the communities to come forward and to be able to self-reliant in many ways. Like they're much more financially independent now, and I would say it has boosted their confidence level, and they have been taking care of their families. And in many cases, many of them have lost their families, or something happened to their parents. They have lost their parents, but they have mentioned that this particular job has done such a miracle for their lives. Like it has been a mental strength for them because they are connected to the community through this work, and that has given a purpose for living. So that's what BRAC has been doing for the community mental health at the moment. Thank you.
Thank you. Thank you for giving us your description of the journey that BRAC is taking. And we'll come around again. We'll understand a bit more on how it's been the model. It's very interesting to know about the model. It's a tiered model that you've talked about.
Mhm.
And we would definitely come back to you with, we need to know more about it. And I would like to talk to Ms. Munira Rahman now, and if you can tell us about how IWF with mental health first aid is contributing to in community mental health care, and how far have you reached over the years in terms of CMHC? So if you can just
Thank you, Malkapa. So actually, as Nafisa was telling that, we have very few mental health professionals available, and those who are available are mostly in Dhaka based and also in big cities. So what is happening in the rural communities? What is happening where these people are not available? These experts are not available. So mental health first aid is an international program. It's currently being implemented in 27 countries, including Bangladesh. It started in 2000 in Australia. Like physical first aid, we know that what we have to do before we go to a professional, if we have a cut or broken leg, and the general population just provide the initial support, and then they take them to the professionals. So similarly, on mental health, when we have an injured mind and soul and body and shattered, so what the community people can do, like maybe family members or a teacher or a employer or colleague, friend, anyone can be a mental health first aider through a training, quality assured training program, which is 12 hours training. And we teach people on common mental health issues like suicide, depression, self-harm, drugs abuse, eating disorder, and psychosis type of issues. And then we discuss about, we train them on a mental health action plan, which teaches them how to how to first assess the risk associated with any mental health condition, and then how to provide immediate support to mitigate the risk, like suicide and self-harm, or even in psychosis. Then also we teach them how to listen and communicate non-judgmentally, which is very important. In most of the cases, the person with mental health condition are stigmatized. So it is important that what languages we are actually using for communicating with the person, so that the person doesn't feel stigmatized, and rather they feel confident and encouraged to seek professional help. They can also provide evidence-based information to educate the person about the mental health issues, and then encourage them for seeking mental health support if it is needed. They also help the person to learn self-help strategies, like different types of meditation, mindfulness meditation, yoga, relaxation, breathing exercise, those sort of things. And then they can seek this support from different professionals. So this is a journey where actually mental health first aider can accompany the person and can help the person to feel confident to seek support, whatever support is needed. And they follow up the cases as well. So the problem we have in our mental health services is that there's no follow-up system at the moment. So a mental health first aider can actually help the person to seek the follow-up services as well, can monitor the recovery process. And the most important thing is here that we actually help community to destigmatize mental illness, because when we work with the participants, we go through, like, their frame of reference about mental illness, and we see that a lot of negative languages are associated with mental illness, and therefore we have to actually de-learn these languages and relearn the empathetic language associated with mental illness. So there is a cultural shift through this training program. So we create the mindset, the positive attitude, the empathy towards a person with mental illness. So this mental health first aid is not just for the person who are affected, but also for the family members. Often the family members are not in a position to provide the adequate support to the person, and therefore they need to be educated as well. Similarly, we do that in schools. It's very important, the youth mental health first aid program that we have, which also educate teachers to learn how the students' mental health is going through, like especially now in this post-COVID situation. So this mental health first aid actually helped teachers to understand the mental health issues of the adolescent and young people and can communicate properly with them. So we have been able to train 62 national trainers since 2015, and 5,000 mental health first aiders across the country. And they are actually working in any place, like in bank or in corporate or school or in NGOs. So there are mental health first aiders in workplace who are actually helping to promote mental health services in the workplace as well. So our motto is to integrate mental health first aid in the primary healthcare services, which is very important. If we are able to train all the community clinic workers, or even Upazila health workers, nurses as a mental health first aider, teachers as a mental health first aiders, that can bridge the gap in providing initial support at least, and can signpost the person for help. Thank you.
Thank you, Munirapa. Thank you very much. It is a very interesting journey that you've taken for Bangladesh with this mental health first aid. We can all say that in this part of the world, and also it's also true for many other countries as well, there's a severe lack of mental health professionals. We know that. There's a constraint there. So if we can have a kind of as you're saying, that if we can train many people on mental health first aid, and another, the BRACS program for para counselor or para professionals, these two in a combination will be able to address mental health at the community level, which will help in a way of before even escalating the mental health challenges for different people to a level where you need professionals, psychologists, psychiatrists, and other counselors. Before that, if it can be handled, it'll be so much easier, and it'll be a lot more people will be able to access mental health support. We've just, Dr. Prashupatinath actually joined us. Let me just give a brief introduction to Dr. Pashupati Mahat. He's the Chief Technical Advisor and Senior Clinical Psychologist, Center for Mental Health and Counseling in Nepal. Welcome, Dr. Mahat. We've started the session. And if you are, can we start with you with your first round of question? Is that all right?
Yeah, it's okay. Thank you so much, Sajid, for your kind introductions. It's okay. I'm ready to go on with
Okay.
the question.
So, okay. Thank you. Thank you so much. What we were talking about is community mental health. So we would like to know the scenario. What's the scenario in Nepal right now? And what is being done for the community mental health care? And how are you doing it in the context of Nepal mental health perspective? Thank you.
Thank you so much for your questions. Let me just briefly explain you the mental health scenario of Nepal. Uh, I don't know whether I can show the PowerPoint presentation in this stream live or not. I don't think so. So it's okay. I'll just talk about it.
Yes.
The Nepal, the country, it has a 28 million populations, and almost 72% um, countryside is being bordered by India and remaining by another big country, China. The country has a quite heterogeneous climate from a very cold to very hot temperature within 500-kilometer distance. So it's a climate and it's a geography and also the people's life. It has a quite big influence in the mental health. Similarly, Nepal is a country from where almost 6 million peoples are migrated in abroad, mainly Gulf countries and Malaysia, South Korea, and other developed countries for my employment purpose. So the left behind family members are equally in a big stress situations in many occasions when the migrant workers is not able to get proper job or is not able to um, send the earnings, or when they are in a even big health and other difficult legal difficulties. Similarly, country also has a big range of population experiencing high level of poverty, almost 25% populations, and it's often experience various kinds of disasters, natural disaster like floods or landslides or road accident that kills more than 10,000 people every year. And on top of that, we are also equally and highly affected by COVID pandemics. Um, though the country is now recognized as a federal Republican country, but still, the political situation is not so much stable. So, why I am taking a reference of political situation, because it has a lot of impact while developing services and planning in the field of mental health in the country. So far, we have last year the previous government approved revised national mental health strategy, which we consider as one of the landmark in the development of mental health service throughout the country, as this national mental health strategy has clearly outlined how the mental health service can be integrated into the primary healthcare service for basic mental health service, and similarly how secondary mental health care service can be developed and promoted by the government, and how the resources can be utilized to develop mental health service throughout the country. There are also some developments since last 3 years, though the priority is very less since many years, but since last year 3 years, government has established separate focal unit in Ministry of Health to look after mental health service issues, and also to promote mental health mainly to integrate primary mental health care up to the community levels. So that means the unit has developed standard training package for the health workers of primary care services. It has adopted WHO mental health gap training package, which has a 6 days training for the primary healthcare workers. It is a more clinical based trainings, and it is added by frequent clinical supervision by the expert like a psychiatrist or clinical psychologist or psychiatric nurses. So this package has been already enrolled, and now health workers of 40 districts receive these trainings. However, its effectiveness is equally challenging because frequent clinical supervision is becoming a big challenge in government systems. Uh, because of the lack of psychiatrists in the government systems, and there has not yet been placed a clinical psychologist in government mental health systems, and no psychiatric nurses are yet placed in the system, though there are the academic courses and there are the people who graduated for these three disciplines. Majority are working in private institutions or like NGOs, mental health NGOs like CMC and other few NGOs. The other part is within these 3 years, government has enlisted 11 psychotropic drugs into the essential drug list and kept it into the free drug list. That means these 11 psychotropic medicines are made available up to the primary care level to treat common mental health problems from the primary healthcare facilities. That includes medicines for the depression, anxiety, psychosis, and epilepsy as well. So, this changes has slowly supporting many people with mental health problems, but it has been very much being supported by NGOs like CMC Nepal, because we are working in 45 districts already, and we are very much involved in providing capacity building training to the primary healthcare workers, and also awareness raising activities in mental illness through female health volunteers who are the big cadres in Nepal for the campaigning of the health issues, including mental health problems and stigma and related stigmas, and helping people to bring to the treatment facilities where there are trained health workers or counselors are available. Another change is we have seen is there are three tiers of governments in federal system: federal government, province government, and local governments, which we often call municipalities. So most of the programs are being implemented by municipality for primary mental health care services. So organizations like CMC is very much working in collaboration with the local governments, and they are showing quite a good interest to have a trained human resources. Like they are even increasing their budgets to have trained psychosocial counselors who are mostly trained for 6 months advanced counseling trainings accredited by Ministry of Health. Similarly, there are also training programs available for the nurses, so that nurses also can be mobilized to provide basic mental health services, primary healthcare services. So these are the changes, the development we have been seeing. And budget also, this year, not this year, last year, there was a 1% of all total health budgets was invested in mental health, and this year also it's the same, which was slightly better, but it's grossly inadequate because a large number of the health workers that needs to be trained, and medicine supply is grossly inadequate and not regular for all the years. Also, trained counselor, trained health workers, or psychiatrist movement for clinical supervision is also a big challenge. However, there are a lot of discussions is going on. Just we have, I was in Nepalese Psychiatrist National Conference the day before yesterday in eastern side of the Nepal, where both central level governments and mental health professionals are discussing with the support of WHO how to mainstream mental health care services at all level. That means local government level and province level, because most of the hospitals with the bed capacity of 15 and above are being managed by provincial governments, and there are psychiatrist placement in most of the provincial governments so far, though not in all high, higher level bedded hospitals, because there are more than 35 hospitals having bed capacity for general health services of 200 bed capacities, and having every day 200 to 250 patients receiving services, inpatient and outpatients. And the government is prioritizing to establish inpatient and outpatient mental health services. We are more advocating with the government that to have a multidisciplinary teams to address mental health services. Particularly, these hospitals receives mental patients from primary healthcare facilities looked after or treated by the trained primary healthcare workers, where there are the services. Otherwise, mainly people themselves visits from different sources. And we are also, particularly CMC Nepal, very much working with the local government. We are sensitizing elected representatives of all local levels, including each tool, village, settlements, and ward levels of the municipality, so that these elected members, if they understand mental health problems and issues very well, then they themselves can refer to the service facilities. Also, they can plan the budget and activities in mental health, which is happening now. Started by many local governments. That means municipalities where CMC Nepal is working.
It's
Uh,
a it's interesting
yeah.
to know how the government and the NGO sector working together in the space of mental health. And thank you for giving us kind of understanding how it's working in Nepal. It's also encouraging to see. I have to also share another fact with you that. Budget wise, even Bangladesh is very much like Nepal. Only about 1% of the budget is spent for mental health, which is also just like Nepal has been. There is an increase, but it's definitely not adequate. We'll be coming to you again, Dr. Mahat. Let me go back to Nafisapa and address again. The question for BRAC's effort for mental health, community mental health. We would like to know about what are the challenges that you're facing, and over the past few years, also if you can tell us, if you want to, the model, that the tiered model that you've been practicing for the displaced community, Rohingya community. What would you suggest? How can a model like that can be mass scaled? What should be the focus for that? Nafisapa, please.
Thank you, Appa. I would take the first question later. I would just want to focus on your second question first, if that is okay. And the thing that we are trying to do in BRAC, and also we have got to work with several other organizations as well. We are trying to scale up this model now because it has proven to be very effective at the community level. And for scaling up, actually, we have been transferring the paracounselor skills, basically. And also we can train the frontliners for identifying cases. But the troubles and the challenges that is we don't have adequate number of psychologists in the country. So although BRAC has enough psychologists at the moment to train up the paracounselors that we have and for scale up process for other programs in BRAC other than mental health, but I think it is going to be a huge challenge if we want to scale up the model. We need to have more psychologists to be here to train up the paracounselors and to have this handholding process that we need to do to ensure that the paracounselors actually are in the right track in terms of intervention and practicing their skills. So we are really wondering how the other organizations are going to accommodate this model, because the challenge is to have the experts and the psychologists. As you know, we are already in scarcity of that higher level expertise, and that has been a challenge for many other organizations as well as BRAC itself. But I think this is something we need to work together for. And if we come together and we handle this tactfully and whatever expertise we have, and we I mean, somebody may have the expertise in child mental health, and the other maybe is very much adequate with geriatric mental health skills. So we might need to have a idea transfer and skill transfer within the organizations that are working for mental health in Bangladesh, and that would be wonderful to just share our skills and to have interchange programs and to bring about all the efforts that we have and to share it and to offer the paracounselor model to have a better scale-up process. Thank you.
Thank you so much, Nafisa. It's very aptly expressed that we do have this lack mental health professional, and if we can collaborate and share resources and see how well it can be utilized for the country, that would be possibly the way forward for all of us. Munirapa, a very much similar question. What are the challenges that you've been facing in the last few years, and where should we focus now to scale up the initiatives at the mass level? What can be done? Thank you.
Thank you. Actually, it's a very important question for us, actually, because we are facing lots of challenges. And one major challenge is that people are interested to take this training, but they are not in a position to pay for the training, because you know that there are costs associated with this sort of training program. And if we are if we want to do that across the country, and obviously we need more trainers. We have trainer training program as well. As I said, you have 62 national trainers, but still this is not adequate. And then, for integrating this mental health first aid training program within the primary healthcare services like community clinic level or Upazila health complex level, it needs huge resources. If we are thinking about at school level, this mental health first aid program, still it needs huge resources. So we are thinking about a way that we can do, like, we can train in that teachers training program, where they can actually take this training further for the teachers, like the same way for nurses training program, or for community clinic workers training program, that we can actually build the capacity of the trainers, and then the trainers can actually take that to the at community level. But still, this needs a quality assurance, because you know that if we just leave it as it is, then there might be a risk of ensuring that the people are actually delivering the mental health first aid training program in a quality assured way. So obviously we have to report back to the International Mental Health First Aid International for this quality assurance as well. So we have to make sure that things are in an appropriate way. And it's also obviously it's evidence based. So we are appealing to Bangladesh government. Obviously, that it's not just the health ministry's work. Obviously, not the mental health is an issue of the education ministry, the women and children affairs, the youth ministry, the sports ministry. Everyone's business actually mental health. So if they are taking this mental health first aid program to integrate within their approach, that will really be helpful to rolling out this training program across the country. And we are happy our trainers are qualified trainers, and therefore we can actually provide the even the trainer training as well in country who are interested. I'm really thankful to PHWC because they have taken this training program and already they are running these courses. SAJIDA Foundation has this, in their mental health program. They have taken that, and the community workers, that their lay counselors are providing mental health first aid program, and many others organizations. So I hope that the other NGOs will come forward, the donor community will come forward, and in that way we will. It's a very low cost model actually, and we can do that quite easily. That with the non-mental health, non-technical people. So it's very important that we need to educate people at least on a first aid basis, and we can do that easily with the
Thank you,
capacity that we have.
Thank you, Munirapa. Again, very rightly said about the sharing resources and collaboration between different government agencies, NGOs, and mental health workers. Let me come to Dr. Ashik Salim. Let's hear about Sajida Foundation. What Sajida Foundation is doing in the community mental health space, and enlighten us about the strategy that Sajida Foundation is taking up to scale up mental health program in the future.
Thank you, Malkapa. It's been a very interesting 45 minutes listening to Nafisa Appa and Monira Appa. Um, the thing I like in particular, I'll come to your questions a little bit later. I'll just talk a little bit in general first. The thing I like about the mental health community in Bangladesh is that it's relatively small and we get along. So the possibility to collaborate is good, and we do it. So this is the one of our strengths. If we look at how we can scale up and how we can do projects, the fact that we get along is a good indication of that. So I would like to just go a little bit basic and say that when we talk about mental health and we talk about scaling up, it's very important to understand the difference between mental health and mental illness. Now, mental health is something that belongs to all of us, and it's like Munira just mentioned, that it's not a health thing, it's not a psychiatry thing or a psychology thing. It's a concept which actually belongs to everybody. And I think that when we integrate things like mental health first aid into a curriculum. So, teacher training, nurse training, MBBS training, developmental studies. I think that unless we integrate some kind of basic understanding of mental health, it's like I worked in the UK for many years, and then I worked in New Zealand. And when I would join a new hospital, they would immediately, you'd have to do fire training, you'd have to do CPR training, you had to do back training, so that you sit properly, you don't have low back pain, and you don't go off sick. These were mandatory trainings every hospital you join. So we should actually, especially in the development sector, now we have gender-based violence awareness. We should have mental health first aid as a mandatory certificate required for development work. Or if you're working with children, you're working with women, you're working It's one of those things that it should be there, mandatory. So that's one thing. The second thing, I think Nafisa and the BRAC model of actually looking outside mental health professionals, the people who are trained to deal with illness, looking away from that and looking how we can actually create a pool of people who can do the bulk of the work is the way forward. Um, and I think the para counselor model is well established. It's internationally there's a lot of studies. BRAC has pioneered this, and I think this is something that we definitely need to look at. Um, One more thing I just want to say before I move on to what Sajida is doing is that I strongly believe that, I mean, when I was in university in Bangladesh, there was Dhaka University, there was the government universities, and then there was IUB, and then there was North South University. Now, if you look at the workforce that we have in Bangladesh, and we look at the number of students who are graduating every year, now, I mean, I don't have the numbers on hand, but a significant proportion of those numbers are coming from private universities. Now, for whatever reason, and the reason for this is, that I'm sure the people in administration have a valid reason, but there is no mental health related degrees which are being offered by any private universities. Now, if we want to produce more counselors, like Nafisa Appa mentioned, Dr. Pashupati also mentioned, and Munira Appa also mentioned, and I'm also mentioning that we don't have enough psychologists. So if we don't have enough psychologists, because the government university can produce maybe 30 or 40 every year, but we have to get the private universities to start offering various levels. They have to offer a 1 year diploma, they have to offer an undergraduate, they have to offer a master's degree, and it can be in specific. You can have a master's degree in addiction counseling, you can have a master's degree in clinical psychology, in health psychology. Again, we were mentioning collaboration and geriatric mental health and child mental health. There's a million fields of mental health which need to be offered, but right now the entire burden is falling upon the government mental health or the psychology counseling departments, and this is unfair. So this has to happen in the near future if we want to increase the number of professionals. So that's just my little rant before I actually go to your question. The question that you asked is, what is Sajida Foundation doing to address community mental health? So the first thing that we've done is we've set up a hotline service, right? So my passion is clinical services. I feel that we need to be able to provide some clinical services and quality clinical services. Obviously, there are many services, private and government, but I feel that there is a space for clinical services from the non-governmental sector. So we have set up a hotline called Shajan, which provides free counseling to anybody who calls it. It's open during working hours, I think till about midnight, and is answered by psychologists in training under extreme supervision. So they've finished their master's degrees and they're getting their clinical placement in this service. So by this, what we're doing is we're providing clinical experience to people who need it, and we're providing a free service in the hotline, along with a referral pathway where they can go on to seeing newly graduated counselors or more senior counselors or a psychiatrist as and when needed. So it's a tiered service. It's free at the point of access. However, if they need referral onwards, then there's a nominal cost involved for that. So that's one way we're doing this. The idea of this is that, say, for example, if people are doing a para-counselor outreach service, yes, we want to try and encourage them to access local services, but having local services up and running is a long process, and it's going to take a while before that happens. Before, like Dr. Pashupati mentioned, the MH gap training, where you're training healthcare professionals in the community. Before that happens will be a while. So in the meantime, the para counselors, the barefoot counselors, the community workers, they need to have a point of access where they can refer. So we've created this service, which is scalable, because our next plan is that we would like to have para counselors who are answering the phone as well. So currently, we're working with an organization called the Banyan Project or BAM in Chennai in India, who are helping us train highly skilled paracounselors. So it's not, normally the paracounselors that we've been training within SAJIDA for until now, it includes a relatively short academic placement followed by practical placement. The BAM project is a 6-month long project, and it gives you a diploma in community mental health care. So the people who are coming out are far more skilled. So what we'd like to do is we'd like to have them so that they can at least triage the first layer of the hotline. And then from there, we then move on to the intern counselors, the counselors, and then the psychiatrists as and when needed. So the first thing we're doing is we made the hotline. The second thing we're doing is we're trying to train highly skilled paracounselors who can try and take the first level of care. And then after that, we focus on obviously the counselors and the psychiatrists. So these are kind of the direct things we're doing right now. And yeah, so I think we have a number of other projects, but it's not necessarily related to the community mental health care. So that's
Thank you, Dr. Ashik. Again, we see that the lack of mental health resources, mental health professionals, what we need to do, and interesting suggestions came from today's discussion from everybody, and we should be having these conversations in a larger scale with relevant government and private sector players in the field, and not necessarily, as Munirapa said, that it doesn't have to be from the field of health or from the field of specifically mental health. It can go beyond, and as Dr. Ashik said, that including first aid, mental health first aid in the curriculum for everybody. And these suggestions should be talked about and taken to different stakeholders so that these are taken seriously. Very quickly, I would like to come back to Dr. Mahat. If you can give us very quickly in 2-3 minutes about the challenges that you're facing taking the primary healthcare facility and combining mental health with it. If you can just give us a bit of understanding on that, Dr. Mahat. Unmute your, yes.
Hello? Thank you. Sorry, it was on mute. Yeah, the challenges are quite similar like in Bangladesh. We have a grossly inadequate human resources for mental health services, particularly qualified human resources. And also, another challenge is mental health and mental illness, as Dr. Ashik rightly defined. There is a very little understanding in all sphere of the peoples, even in highly educated peoples, the understanding of mental illness is quite different. The educations on, particularly need of mental health service, and that most of the mental illnesses are treatable and are recovered with a timely and due course of either medicine or counseling or both, psychological treatment or the psychiatric treatment. And also, timely, health service seeking, mental health service seeking attitude is very much challenging. The other big challenges is stigma in the mental illness, because in our part in Nepal also, the mentally ill people is often labeled as mad people. Even you are just having some kind of anxiety problems or some level of depressions, but all kinds of mental illnesses are labeled as a mad persons, psychotic persons, though that is quite different types of the mental illnesses. And the other big challenge is, the government's establishment of mental health service into the primary healthcare facilities and building mental health services is quite slow, though something is happening in the last 3 years. But we are now very much in discussions with the collaborations of public-private partnerships, particularly like how uniform psychiatric training courses we can make it, and how the resident psychiatrists can be mobilized into the primary healthcare facilities as a exposure to community psychiatry, so that they could supervise and train community workers in mental health as well. A similar practice we are trying emphasizing in the training course of psychiatric nurses, and then in the psychologist master training program, so that these academically trained qualified peoples would get exposure in the community level, and they would contribute into building the mental health capacities of the community level peoples. We are also equally discussing with the Ministry of Education, particularly building some content of basic mental health problems into secondary level educations, where there has been a very good progress. We are now in a very good shape that depression, suicide, and then anxiety, substance abuse contents are now accepted in grade 9 and 10, grade 9, 10 and 11, which we are quite perceived as a good achievements if this concept would be delivered in the schools. And school nurses are already in process of getting training for that. Nepal government has placed one school nurse in process of placing school nurses in most of the secondary and higher secondary schools, so they can address the health and mental health issues, but their mental health capacities is very weak. We are also equally discussing with the medical institutes. As Dr. Ashik said, we are our most of the medical students are producing from private medical colleges, where there are 14 private medical colleges throughout the country. More than 2,000, MBBS doctors are graduated every year from Nepal, though most of them are going abroad for the employment opportunities because of the lack of opportunities in Nepal. We are collaborating and encouraging government that how to mobilize these MBBS students again into their encroachment areas, like in the district where they are running. How the fourth year or intern MBBS students can be mobilized in the community level with the mental health knowledge and skills, so that they can also involve in the service delivery, supporting the primary healthcare workers. So this type of the way out is also going on, but the core challenges is resource challenges, human resource, funding resource. Though there has been slowly development, but the advocacy is still very much needed. And another big challenge is the lack of mental health law that really hinders to enjoy the rights of the peoples with mental health problems, where we are still very much need to work collaboratively with the lawyers and the policy makers with the governments. Thank you.
Thank you. Thank you, Dr. Mahat, giving us an understanding what Nepal is going through. I think we are facing similar challenges. We've just updated our Mental Health Act from Lunacy Act to 2018 Mental Health Act. But then again, whether it is being practiced or not, that's another question altogether. So these are, as I was saying before, that these are the things needs to be actually, we need to focus on these. We need to discuss about this, talk to different people, talk to different stakeholders, and this right-based approach should be reflected in each and every initiative. So these are the things we need to bring about and talk to different people, and that's very important. The more we discuss about it, people would know about it. As Dr. Mahat said, that even a basic understanding of mental health can be incorporated in schools schools, colleges, and different education programs. And these are suggestions, and we need to actually voice our suggestions so that stakeholders are listening to us. I would like to kind of close this session and thank you all the panelists of today. And this is, as I said at the beginning, that this is the last webinar that we are having of almost a 2-month long webinar series of webinars we've had. It has been an interesting journey for us. We've had different speakers from different countries, and we've had interesting suggestions and interesting input from everybody. And I would like to thank our media partner, Dhaka Tribune, and of course, a big thanks to mental health program, SAJIDA Foundation Mental Health Program, for putting a lot of effort of coordinating, putting all these webinars together. I would like to say thank you again to all the panelists today, and have a good evening, and have a good week. And of course, we'll see you again. Thank you.
Thank you so much.
Thank you. Thank you.
Bye-bye.
Bye.
Bye.